Good evening, folks, and thanks for coming on. As was just stated by Ms. Jackson, I have a lot of slides here. I'm not going to read every one of them, but I wanted you guys to have the information. So I'm going to talk at a pretty brisk clip, and hopefully I will cover most of the questions that you might be actually coming up with. I want to start out by acknowledging that the first time I did a version of this talk, it was actually for doing something for managed care in Georgia with people with age blind and disabled, and Dr. G had some slides, and I used a group of her slides. I've expanded on what she initially gave me, but I want to acknowledge that she had helped me out with that. I also have the disclosure. I don't have any financial relationships to disclose. I don't have any investigational meds or anything that I'm going to talk about. The objectives are to make sure that by the end of this conversation or this presentation, you have the ability to discuss the epidemiology, the etiology and pathophys, and some of the clinical features of sickle cell disease, and that you recognize the role of primary care providers, including, and also the emergency ED personnel, specialists, the different care managers, in taking care of sickle cell disease affected individuals. And I thought it was interesting on the poll question that 100% of you felt that one of the issues was really providing a medical home for persons with sickle cell disease, and I would absolutely agree with that. So hopefully the things we cover will help us improve our ability to do that. We also need to recognize age-related complications of sickle cell disease and discuss treatment options for patients with sickle cell disease. And another thing as far as medical home is to identify resources needed to meet the medical and psychosocial needs of affected individuals and their families. So start out with what is sickle cell disease? So sickle cell disease affects it's a blood disorder. It involves the hemoglobin in the red cells, and actually the cells end up looking sickled. And I'm going to go through why that is. This affects about 1 in 400 people of African descent. And the genetic defect, and this is the kind of question that's typically a question on boards or also on CME questions. But anyway, is what is the DNA-based substitution that causes sickle cell disease? And so it's a T substituted for A for adenine, where the DNA encodes the 6th amino acid in the beta globulin. And so this amino acid change causes a change from glutamic acid to valine. Now, when we look at why this ended up occurring anyway, it's possible that hemoglobin and red cell enzyme mutations might have been an adaptive response to malaria. Sickle cell trait improves the survival against malaria, and it's because some of the RBCs with sickle hemoglobin have a reduced lifespan after they're infected with parasites, and therefore they're more quickly removed by macrophages. Okay, now when we talk about inheritance, this is a cute little picture instead of the usual 4-square box. But anyway, if a couple each have sickle cell trait, one out of 4 children, one would have normal hemoglobin, two would have sickle cell trait, and one would have sickle cell disease. Now, a person with sickle cell trait is called a heterozygous, and they're a carrier. They're usually asymptomatic, and about 1 in 10 African Americans have hemoglobin AS. In some parts of Africa, the gene frequency is over 90%, but basically it's 20 to 30% on average. And people may also have genes for other hemoglobin combinations, and these are some of them listed. I'm not going to go into them, but I just wanted to have that included. And this is how you would calculate it out, of course, if somebody had one of these other combinations. And I have the websites where you can get these kind of pictures if you're giving talks on this. When we talk about sickle cell disease and race, okay, the gene variant for sickle cell disease is related to malaria, but it's not related to skin color. So even though it's more common in people of African descent, it does not only affect African Americans, and that's really important for us to be aware of. Therefore, everybody should be screened for sickle cell disease. Quote, white people can have sickle cell disease. Latinos also have sickle cell. You just need to recognize that are people other than just African Americans that have sickle cell disease. There are actually 100,000 people in the United States with sickle cell disease and 2 million with sickle cell trait living in the U.S., and that makes this the most common genetic disease in the United States. Therefore, when we talk about newborn screening, all infants, including those that are born at home, should have blood sent for metabolic screening and for hemoglobin disorder evaluation. Now, some of the life-threatening conditions that can affect people with sickle cell disease are sepsis, especially S. pneumoniae, and splenic sequestration, aplastic anemia, acute chest syndrome, and CVA. Now, if you have a positive newborn screen, given that these are the kind of things that can happen to you, the life-threatening issues, you really need to make sure the family is very immediately informed of the results. You need to see the patient for an office visit as soon as possible, and you need to start doing prophylactic management with penicillin and folic acid. Now, if you have a sickle cell center, I think on the poll question, I think I saw that half of the folks had one and half didn't. But anyway, if you have a, or some, yeah, oh, well, okay, people didn't, some knew. Okay, anyway, thank you. New technology, yes. So half of you had one and half of you didn't. Okay. If you have a sickle cell center, it's good to have a good relationship with them. But again, because we're trying to do medical home, you guys have to kind of work out what are you considering to be that patient's medical home. If you don't have a sickle cell center, it becomes even more difficult because the patient tends to bounce between the ER, the ED, and your office. But if they have a sickle cell center, they tend to be very comprehensive and have all of the different things that I'm going to talk about that sick patients with sickle cell disease need to support their health and wellness. But anyway, if there is a center, you make an appointment with the sickle cell center and make sure they have a confirmatory electrophoresis. If you don't have a center, then you'd still have them have that confirmatory electrophoresis. You're going to do the regular immunizations, and you're going to do the same approach that you would have done for any other pediatric patient, regardless of the hemoglobin type. When you educate families, when you tell families about something that can be problematic, it really helps with providing for early treatment for patients, not just for sickle cell, but for anything. If people don't really understand the degree of impact that they can have in managing the care of their child or themselves, then that impedes our successful management of their care, especially under the medical home version. We don't want stuff to become life-threatening, and we certainly don't want it to be fatal, and so education is as important as medical treatment in these cases. So when you're a primary care provider, I'm a former community health center doc and former medical director, so I know that we don't always have all of the resources that we need or we would like to have. But if you do have any kind of care management, some of the areas of assistance are to make sure that you have appropriate diagnosis, health maintenance, the same as you would have with any other patient. I'm going to keep saying that because often what happens when we have patients that have really severe or life-threatening chronic diseases is we only focus on the issue that is their chronic disease. So with sickle cell, people tend to focus on the pain crises, etc., and they don't think about health maintenance. So as we go through, I'm going to keep reminding you, we need to really think about health maintenance. What you would do for any other patient in that particular age group, you're going to do for patients with sickle cell disease. We have to really educate folks and help and support them, and that takes some experience. It takes some development, skill development, because what might work for you individually in your household as far as education may not work for the particular patients with whom you're working. So that takes some practice, and again, if you have a sickle cell center, that helps. We have to really work on early detection of complications, and we want to treat mild and moderate symptoms. So when I said care management, key areas of assistance, when we have self-management goals, we've done that for a lot of the other areas of chronic disease. So you would have people have self-management goals or goals for what they're going to watch themselves for. If I see signs of this, this is when I'm going to come in. Or if my child has these particular signs, this is when I'm going to come in. Some of the things comprehensive sickle cell centers provide are things such as confirmation of the diagnosis, genetic counseling, like I mentioned earlier, who is also going to, what are the possibilities when you have other children that you're going to have other children that are affected with sickle cell disease. Intensive education and anticipatory guidance, management of complications, social work and support services, the state-of-the-art medical care and clinical research, and transition services for young adults. There are several conditions that folks used to die of definitely while they were teens. I finished residency in the 80s, and most of the patients, when I was a pediatric resident, we had patients dying around 15, 16. Well, now they have patients on average that are living 45 years and longer. There are patients that have lived like close to 80 years. So you have to think about transition services. It's not like you're just trying to keep somebody alive through their teens and you're not thinking about how are they going to be managed in the future, what other conditions can they possibly have just because of aging. That kind of thing. Okay, for the Georgia Comprehensive Sickle Cell Center, again, these are some of the people that are in the pediatric team. I just saw something about, I said I wasn't going to stop and answer questions, but you're right, the PCV13 is correct. I'm sorry. That was one of those slides I apparently didn't update, and I appreciate your pointing that out. It is the same immunizations that you would give other children, and I'm sorry about that. Okay, so now these are some of the other people on the pediatric team. I'm on the team, and these are some of the other services that are provided by, for example, Comprehensive Sickle Cell Center. Now think about it, neuropsych testing. If you're having many strokes basically from having sickle cell, obviously your brain can be affected. That's something we need to think about. What else is going on with these patients other than just what we always know about, which is the pain, okay? And again, some of the goals, we want normal growth, development, and social functioning. We want to prevent and treat life-threatening emergencies, and we want to educate families regarding possible age-related chronic complications and make sure that we keep screening for them. So when we look at age-related complications, in infants and toddlers, we have sepsis, splenic sequestration, and dactylitis. And so we want to make sure that we educate family, make sure they really understand what is sickle cell disease, what is the prognosis. We need to recognize that the parents are going to have fears, and they're going to have denial possibly, they might have guilt. Especially like if they didn't get prenatal care or whatever, didn't know ahead of time that they both had sickle cell trait or whatever. We really need to make sure they recognize to prevent sepsis. In all newborns, we're concerned about sepsis, but with patients with sickle cell disease, we're extremely concerned about it. We also want to follow up on, we want to talk to them about their spleen, and we want to talk to them about dactylitis. So when you use prophylactic penicillin, it reduces the incidence of pneumococcal sepsis by 80%, and all patients, again, should know their sickle cell status. Now, this goes through the penicillin prophylaxis directions. I'm not going to I can't go through each one of these in detail just because of time, and like I said, I have so much on these slides, but I did give some resources where you can look, and definitely the cdc.gov is one of them. You want to make sure that parents know how to take the temperature. Rectal is preferred. You want to recognize when child has fever and respond, and you want to make sure they know the definition of a fever. You also don't want them to treat for a fever until the child has been evaluated by a physician, because we really need to know what that temperature actually is. And so if they have a fever, we have to emphasize that you need to go immediately to the doctor's office or the ER, because we're not telling them not to treat and don't come in to see us. We need them to come in to see us. Splenic sequestration can happen as early as 2 months, and it can happen up to 4 to 5 years. So we really need people to recognize the spleen, how to palpate it gently, and to inform them about where their child's spleen is at the point when you're seeing them. If the spleen is not palpable, you that's good to know. And if it is, you give them a spleen stick and let them measure that. And some of the things with splenic sequestration is the pallor. They get lethargic, they have poor feeding, and their palms and soles are not going to have normal color. So those are some of the signs. This is what a spleen stick looks like. You go from the nipple, you take a tongue depressor, for example, you put it at the child's nipple, and you place the tip at the left nipple, make a mark where the spleen tip is felt. So you come down to where the spleen tip is felt. So if you're consistently lining that stick up, then you'd know if there's a change with that. Dactylitis is the hand or foot swelling, and obviously if your hand was like that, the child would start crying. They wouldn't be moving it that much, and they usually aren't consolable, and it can occur with infection. Again, this can start very early. Sometimes this is one of the first signs that kids even have that shows sequela of sickle cell. If they don't have a fever, you can give lots of fluid, give ibuprofen, Tylenol with codeine elixir. But if the pain's not relieved in 1 or 2 hours, they need to come on into the ER. Now, going just for routine care checkups, you want to do the same as a regular newborn, and you want to do them with a regular recommended frequency. Again, now we're moving up to toddlers. You want to prevent sepsis. You always want to manage and prevent pain, and you have to be watching what's going on with the spleen, watching out for chest syndrome, stroke, and developmental issues. Again, we need to, Okay, now with bacterial sepsis, children with sickle cell disease have an increased risk of bacterial blood infections because of having splenic dysfunction. The spleen can be completely infarcted by 4 to 5 years, but it's dysfunctional very early in life. And before we had penicillin prophylaxis, pneumococcal sepsis was the leading cause of death in children less than 5 years. Another thing with splenic sequestration, which can continue into this age group, the spleen becomes significantly enlarged versus baseline, and the vessels are engorged with blood. You have a rapid drop in the hemoglobin. It's often associated with viral illness, and it can be rapidly fatal. When we talk about sickle cell disease and we talk about pain, part of that is because of the blockage of the blood vessels by the sickle cells. And how this happens is that you have decreased flexibility of the sickled cells, and you have an increased adherence of the red cells to the vascular endothelium. In other words, the blood is sticky. So it's not just that the cell is sickled and therefore blocks the flow, but it actually has a difference in how it adheres to the vascular endothelium. So the mechanisms are believed to be that there's polymerization of the hemoglobin molecule. It becomes a sickled shape and very rigid when it's deoxygenated. It then occludes the blood vessel and leads to endothelial dysfunction. You have tissue hypoxia, organ damage, and increased RBC fragility, which causes destruction, and that's how you get to the anemia. Now, with organ damage, vaso-occlusion, of course, can cause damage to any body part, but the brain, the things we really think about are the brain, the lung, the bone or bone marrow, spleen, eyes, kidney. So infarction is tissue damage due to the lack of the oxygen in circulation. And so this is partly the cause of the pain and partly the cause of the long-term life-changing sequela of having sickle cell. With children, they often have pain, they have anemia, they can have the acute chest syndrome, they can have ischemic stroke, and they can have learning problems. With acute chest syndrome, we need to recognize that hypoxia can kill the individual. So even a minor respiratory infection or illness can progress and lead to hypoxia. So some of the warning signs are progressive cough, wheeze, chest pain, and fever. And again, this is the kind of thing that you want to make sure you have discussed with the parents so that the family members are watching for these things. You want to always evaluate all patients with sickle cell disease and any respiratory symptoms, and hospitalize any of them that have a pulmonary infiltrate on their chest x-ray, focal lung findings, and or hypoxia. As far as strokes can occur in children as young as 2 to 3 years of age, and children less than 15 it tends to be ischemic, and in adults and adolescents it tends to be hemorrhagic. And the patient usually complains of severe headache, visual changes, weakness, slurred speech, behavioral changes, and seizures, plus or minus seizures. And so obviously this is something we need to evaluate immediately. As far as school-age children, we need to manage and prevent pain. Again, identifying the precipitating factors and looking at the things that can tend to happen in that age group. So they tend to have the chest syndrome, stroke, they can have priapism, gallbladder issues. We need to make sure they have annual eye exams beginning at around 7 to 8. We need to watch their growth and development. We do expect them typically to be smaller than their peers, but we still are going to watch because we want to optimize care in every area that we can. We need to think about self-esteem and coping behaviors. Now we always, back to medical home, anytime you're taking care of pediatric patients or whatever, you're aware of issues in school and what the child's self-esteem is. But these, again, people that have something like sickle cell disease and have these lifetime challenges that other kids don't have, end up having major issues with self-esteem. They can start having behaviors that aren't appropriate. They can have pica, they can have enuresis, they can have problems with their school functioning, especially if they're out of school a lot, or again, if they can't do the things that other kids can do. So you really need to, as far as the medical home is, make sure that you are thinking through these other issues to make sure all of these needs are met and addressed. Again, the children with sickle cell can have delayed somatic growth, and they can have developmental or learning problems. So we need to really screen them, follow up with that, see if we need to give any nutritional supplements, and make sure that with school we're doing early intervention services. Now pica, that's one of the behavioral issues that's possible. It's common, and it can lead to bowel obstruction. And it can be anything that somebody eats that's unusual. So you need to ask the question, does your child eat anything unusual? Usually people don't want to say their child is eating the headboard, but they also think their child is the only child around that's doing something like that. So we need to ask the question, or it won't get answered. When we talk about coping and self-esteem, again, children often have altered self-image. They're embarrassed about how they look, how thin they are, or if they're limping because they've had different issues with, where the sickled cells have adversely affected them, maybe in their hip joint or whatever. So they're embarrassed, they have a lot of absenteeism, they are teased, they might look jaundiced, and so they get teased about that. That's a problem. They have small stature or any other developmental differences. They might have problems with sibling rivalry. Think about it. If you're the child that uses all the family resources in terms of time and money and energy, then your siblings may not be all that happy with you. And they can also have adjustment issues. As with any other condition, how one perceives oneself with a given condition plays into their success with existing with that condition. So for example, somebody can be born without an arm or without several arms, or both arms or leg or whatever, and they can have an attitude such that you're just amazed at how they function and go on through life and are successful. But other people just go through life with a sick person attitude. And so again, given that individuals with sickle cell disease are living longer, we can't have them just have a sick person attitude, knowing that there's a possibility they're going to be here for a long time, and they need to take advantage of the opportunity to continue with survival and improve the quality of that longer life. With adolescents, they have recurrent or chronic pain. They can have growth or pubertal delay, priapism, and renal disease. And so priapism is a sustained painful erection. It's most common in males that actually have sickle cell disease and a hemoglobin SS, and it can be in infancy, but usually after age 4 to 5. If they have recurrent issues of it, it can cause impotence. And another thing we need to talk about is the anticipatory guidance. We do anticipatory guidance with any child or young adult, young person, but now we have to specifically define and explain a normal erection and what to do if you're having an abnormal erection, and have early treatment, fluids, pain medicines, and go to the ER if it's not improved after an hour. That's graphic, but anyway, it occurs in 38 to 42% of all adults with hemoglobin SS at least once in life. Proteinuria is another issue. Renal dysfunction is very common in adults with sickle cell disease, and it can lead to renal failure and the need for dialysis. So whenever you're seeing a patient with sickle cell disease, you need to screen them with a UA, and you need to refer the patient that has proteinuria or any other such abnormalities onto a nephrologist. They can have cholelithiasis. Bile stones are seen as early as 4 to 5 years. 50 to 75% of patients with hemoglobin SS will actually have their gallbladders removed by the time they're 18, and it's more common in hemoglobin SS. Okay, now some of the symptoms are recurrent right upper quadrant pain and jaundice, and what you'd want to do is get an abdominal you want to get an abdominal ultrasound if those symptoms are present, and consider doing having a cholecystectomy done if recurrent symptoms episodes occur. With adolescents, you're really getting into managing pain and the medication usage patterns. This is really an important time period. Of course, we've started back when the child was first born, but now it's transitioning to a point where the adolescent's going to be more responsible for their own care. And as we know, with adolescents, that's a time when you're going through a lot of changes in general. So this is a very specific change and a specific issue. So we really want to admonish the young person about the issues around possibly having chronic organ damage and the need to be keeping up with what's going on, the need to eat properly, keep well hydrated, etc. And we need to help them with their self-esteem and coping, optimize their school functioning, look forward to what they're going to do long term with their life as far as vocation. We also need to talk about reproduction and contraception and genetic counseling. And another thing is to think about transitioning to adult care providers. Often we are so into taking care of children, we being pediatricians, that we're used to taking care of them, and about the time they go off to college or whatever, that's when they transition out of our practice. But if you have a child that has a chronic illness like sickle cell, that has all of the different issues related to that, then you really need to make sure that you have a smooth transition to the adult care providers. Some of the other behavioral issues are enuresis, and the question is whether it's from reduced concentrating function, or is it developmental, is it bladder volume issues. What you can do is the typical approaches, behavioral modification or using alarms. But we also need to be really watchful, not necessarily just in adolescence, but at any point, to see if folks are using pain as a means to avoid school or to get attention. And this is one of the major problems with this whole condition, is it's hard to know when, it's hard for anybody that's not having the experience themselves to know what is truth and what's fiction, and we tend to err on the side of saying it's not true. So if you're working with a child from early on, you can kind of try to temper this whole issue. Some of the age-related complications with adults, they can have proliferative retinopathy, avascular necrosis, they can have leg ulcers, a hemorrhagic stroke, gallstones, or cholecystitis. And the retinopathy is more common in adults, but you can start having vision problems in childhood, and it's more common in those with a higher hemoglobin S. An annual eye exam by an ophthalmologist, routine exam, and dilated exam to rule out retinopathy are recommended. And this is what the retinopathy looks like, and it can be due to the macular infarction because of sickled cells. Now, avascular necrosis, It really can affect the hips and or the shoulders. It's more common in hemoglobin SC, and it can appear in children, but it's more common again with increasing age. So they have recurrent hip, leg, or shoulder or arm pain, and what you want to do is screen with an X-ray or do an MRI if clinical suspicion is very high. And we also want to be checking these kids for scoliosis. We don't just check folks that don't have chronic illnesses. We check everybody for things that we check everybody else for. Some of the clinical manifestations with avascular necrosis, some of the other clinical manifestations are hemolytic anemia, vaso-occlusive episodes, which are very painful, which can also lead to chronic organ damage and are the reason for a reduced life expectancy. Now, with hemolytic anemia, you have a really low blood cell count, and a normal hemoglobin level is 13 to 15 grams per deciliter, and a person with hemoglobin SS is 6 to 8. And hemo, is blood, lysis is breakage. So the blood cells are fragile, they break more easily, they lead to the jaundice and anemia, and then a high bilirubin. This is a RBC lifespan. The normal red blood cells are 120 days, and sickle cells can be 10 to 20 days. Now, this is something pretty significant too. Transient red cell aplasia. The etiology is parvovirus B19, and what it actually does is it halts the production of red cells for 3 to 7 days. Well, in normal individuals, where you have 120 days of the life of a red blood cell, that doesn't cause any symptoms. But in patients with sickle cell disease, they can have a precipitous drop in their hemoglobin levels. And what you would do to test for transient red cell aplasia is look at the hemoglobin and the retic count. So if they're both low, that's probably transient red cell aplasia. You want to isolate pregnant patients and healthcare workers, because you don't want them to pass this parvovirus on to those people. Acute chest syndrome, you can have hypoxia, which is the low oxygen, and it can cause a progressive cycle. You have the sickling in the lung, you have further hypoxia, and of course if you continue with that, then you can end up with death. Acute chest syndrome, by definition, is shows an abnormal area on a chest x-ray, and it's often associated with fever, cough, difficulty breathing, chest, abdominal, or back pain, and a worsening anemia. And some of the causes for acute chest syndrome in children is usually infection, bacterial or viral. It can be the sickling or the infarction in general, and in adults and adolescents, it can be actually an embolus from the bone marrow. You want to treat as if asthma, well, first of all, if the patient has asthma, you want to treat that if present. Again, this is that whole medical home thing. We're not treating the patient just for this particular disease. We don't act as they are sickle cell disease and all the other things that can cause wheezing or whatever in another person can't also cause it in this patient with sickle cell disease. So if they have asthma, you want to treat that. You want to treat them with antibiotics. You want to give them oxygen, and sometimes you might need to do transfusions. When they have a stroke, again, that can occur in very young children. Remember, the younger children, it's ischemic, and adults and adolescents, it's hemorrhagic. And again, they have the slurred speech, behavior changes, and seizures, etc. When they have a cerebral infarction, 25% of patients with hemoglobin SS have symptoms that are consistent with silent infarctions. And this is another reason why, when we're talking about education and vocation, you have to recognize we're not always doing scans of their brain to see what's happening, but things can be changing, just like they're having infarctions in their lungs or in their hips or in other places. They can have them in their brain, and so we have to recognize that can be a cause of some of the issues with our patients. Stroke, of course, can cause long-term disability, difficulty learning, and changes in personality. Now, children may improve very rapidly and regain their strength completely, but they may not always have return of their learning capability. And long-term transfusions can help prevent strokes from occurring and can prevent the first stroke in high-risk individuals. Pain episodes are the most common complication of sickle cell disease, and a third of all people with sickle cell disease have pain at least once a year or less. A third have a few episodes a year, and others have frequent pain. So if you look at information like data on ER visits, etc., it really varies. There's some people that are truly frequent flyers, and there are other people that really rarely come in. The pain occurs because of this vasoocclusion, the insufficient blood flow and oxygen, and that causes tissue damage, and that's very painful. It's not life-threatening, but it can be associated with other complications. And again, it can occur anywhere in the body. It's usually in the bones and muscles. And again, in babies, you'd see they'd be very fussy. You won't be able to console them. They can have that hand or foot swelling, or they're not using an extremity. Some of the late complications, we've already mentioned some of these, but gallstones from hemoglobin breakdown, renal disease, mentioned that already. Oh, and pregnancy complications, that's another thing. Now remember I said, again, medical home. We are not just taking care of sickle cell, so we're not just taking care of pain or just making sure the patient doesn't have infections. We're doing the care that we would do for, if it's a female or male, we're doing whatever care you would do for another female or male. So you're going to do counseling on sexuality and sexual health. If they're pregnant, you need to manage them and recognize that there is a possibility of more complications, but we can't just act as though we only take care of the patient for just a small part of all of this stuff that's going on. As far as gallstones, that's a view on that. These are some of the leg ulcers. And treatments, we want to treat the symptoms and complications of sickle cell when and as they're occurring. That involves red blood cell transfusions, antibiotics, oxygen, and pain medications. And the goal is to reduce sickling of the red cells and vasodilatation, vasoocclusion, infections, and pain. Now, the transfusions are used when a person's hemoglobin level is well below their usual baseline level. And this has been one of the most important treatments for patients with sickle cell disease. And the reason being that blood from a donor with a normal hemoglobin will flow better and carry more oxygen. The problem with transfusions is the patient tends to develop antibodies due to minor antigen mismatches. You can have infections, so the rates of HIV and hepatitis C are lower now, but they used to be quite high, and you can have iron overload. And iron overload, of course, damages the heart, the liver, and the endocrine organs. The treatment of pain, again, is increase of fluids, helping improve blood flow, reducing sickling within the red blood cells. You want patients to rest. You want to either put local warmth or massage, and work with the pain medications. Something about the increased fluids. Again, when you're thinking through the life cycle, when you have kids running out to go play outside with their friends or playing in the playground at school or whatever, we have problems with kids in general making sure they stay hydrated. So imagine if you have a child that you really, really need to have stay hydrated. This is one of those things where you really have to start training folks and teaching the child and their family members early on that this is something important that they do have some control over. The treatment of pain, the whole issue of prejudice and pain treatment. A lot of folks view people with sickle cell disease as drug seeking or drug addicts. Most of the patients are African American. You can't necessarily see the site of the pain, and the pain can be frequent and require strong medications. So something that's really important is that we believe the patient. But again, if we're working comprehensively on providing a medical home and making sure that all of these different issues are dealt with, then hopefully we can have more trust and belief that when there's complaints of pain, that there really is pain. Some of the things that cause vaso-occlusion are factors that promote sickle hemoglobin polymerization, and those are high temperature, intracellular dehydration, an increased concentration of the hemoglobin S, and hypoxia. And other things that can worsen vaso-occlusion are vasoconstriction, such as if it's really cold or particular drugs, and adhesion of red cells to activated endothelium. And again, that's due to inflammation in general. So to prevent vaso-occlusion, we want to avoid the extremes of temperature, and we want to drink lots of fluids, treat respiratory symptoms and infections immediately, use anti-inflammatory drugs to treat the pain, and get lots of rest and avoid overexertion. They also need to avoid certain drugs. Recognizing cocaine vasoconstricts, tobacco has carbon monoxide, which displaces oxygen on the hemoglobin, so that causes problems. Alcohol and caffeine dehydrate. That's really important now with all these energy drinks. So you have a young adult or a teenager that thinks that drinking energy drinks counts as hydration. It really doesn't, because those are actually going to cause more dehydration. Cold temperature and inflammation or infection can also cause the problems. Now, some of the treatment approaches that are really important, we want to make sure that we do routine care and preventive maintenance. So in other words, you want what you do with a patient with sickle cell disease to be consistent with what you do with any and all other patients. You want to check their ABCDs, hemoglobin A1C, the blood pressure, the cholesterol, or do depression screens. You need to teach them about knowing their numbers. We need to do breast exams. We need to do mammography. We need to do pap smears, colonoscopy, prostate exams, and immunizations, and of course pain management. And again, that question of medical home, we don't want to be missing these things because we get just tied up in managing the crises of sickle cell disease. Some of the other treatment approaches are to do red blood cell transfusions, the antibiotics, hydration. We need to look at ER management and look at sickle cell pain crisis as a diagnosis of exclusion. In other words, when somebody comes in to the ED or the ER, you should not just think, oh, this is another sickler with pain. Okay, they're trying to get drugs. You need to think, what kind of things are going on in the rest of the population that can also be affecting this individual? And you need to make sure that the things that we know are possible complications in a patient with sickle cell are addressed, but you also need to address things that might be going on in your community in general. Now, some of the other treatment approaches, hydroxyurea, it increases fetal hemoglobin, and so it decreases red blood cell endothelial interaction and density, which improves the nitric oxide metabolism. So that's why the hydroxyurea works. Now, what they've been doing lately is there has been a cure for sickle cell disease, and it is bone marrow or stem cell transplantation. There have been more than 50 people in the U.S. that have had this bone marrow transplant or stem cell transplant to cure sickle cell disease. And basically what it does is it totally replaces a person's blood producing cells with those from another person without sickle cell disease. It is okay to use somebody with sickle cell trait for this transfer, but it's best to use somebody that does not have sickle cell disease at all. Now, the donated bone marrow must have a good match, and of course that's looking at the HLA types, and the best donor is a full sibling. Now, some of the sickle cell touch levels, these are levels where we're trying to make sure when we're managing a patient with sickle cell disease and we're trying to provide a medical home, you want to make sure that you're looking at the risk level with that given patient. So some patients start having a really rocky road from the very beginning. Part of it might be their living situation, how well they can be taken care of in general, what resources the family does or doesn't have. You want to look at risk levels and look at what's going on with an individual. Are they kind of going down the slippery slope of having all the different complications? And you want to stratify those levels based on what's going on with them and see what things you can intervene on. What things are related to their particular behaviors? Are we doing poor me? Oh, I can't do anything, or things aren't going well, so I'm not going to do anything? Or are we working to try to do self-management and optimize our health? You want to look at risk factors and or unmet needs. So again, when you're thinking about this comprehensively, you think about what's going on in school, what's going on at home, what's going on as far as their potential career goals. Are we looking at how well their brain is functioning? Have they had some issues that we've missed along the way that we need to deal with? Are we optimizing if they're out of school a lot? Are we making sure that they have whatever educational assistance is needed and is available for them? And these are some of the potentially effective touch level interventions for an individual with sickle cell disease. Those are some of the kind of things that we would want to look at. And again, so if you're a care manager, do you do home instruction? Is it all the time or is it intermittent? Do you need to make special accommodations for recess? What about restroom access? Do you need to provide for increased restroom access? This comes to you because folks will be asking you for a note for this. And again, the patient may not even think of this. The patient or the parent may not even think of this as an issue, but given that we know these things are issues, these are things we need to address. We want to make sure that they have the opportunity to stay hydrated, and we want to make sure that they have whatever kind of intervention plan is needed.
Yes, we do
to
have
take
a
care
question.
of them. And that ends my
Are you able to
presentation.
see it?
Any questions?